Hello, I'm Morgan. I will be talking about metabolic acidosis as it pertains to the case study I was assigned. I was given the case study 53, which is type 1 diabetes, so I'll talk about the pathophysiology of type 1 diabetes and how it relates to and leads to diabetic ketoacidosis and metabolic acidosis. In my case study, the patient presented with the chief complaint of throwing up since yesterday. She's had a stomach ache and has felt very weak. She is a type 1 diabetic, active 13-year-old female, but otherwise healthy. She's never been hospitalized. She does have a family history of type 1 diabetes. Her older brother was diagnosed at age 10, and her maternal grandmother passed away from renal failure contributed from type 1 diabetes. The patient's mother had noticed that she was looking more pale and feeling less active a few months ago. The patient herself had noted that she has been tired and she's been thinking about quitting the volleyball team. She's experiencing an increase in thirst and hunger and is constantly snacking and taking frequent trips to the restroom. She has noticed that her clothes no longer fit her well, they feel too big, and that she has been going to the bathroom a lot more than usual. Her mother reports the patient has become more frustrated and she seems to have a hard time focusing. This brings us to our history of present illness and present hospitalization. Last night the patient took her blood sugar prior to dinner and it was 193. She then proceeded to take her normal dose of Lispro and ate her dinner. She felt nauseated immediately prior to going to bed and then woke up with a stomach ache. She took her blood sugar again and it read 397. Her mother offered the patient ginger ale and crackers, but the patient was vomiting and unable to keep anything down. Her breathing became labored, so the mother suspected DKA at this time. She takes insulin Lispro sliding scale, NPH insulin at breakfast and bedtime, and additional insulin Lispro if she notes urinary ketones. Type 1 diabetes, which leads to diabetic ketoacidosis and metabolic acidosis at a pathophysiological level. Diabetes is defined by Rogers and McCanson-Hoothers pathophysiology as being a group of metabolic diseases characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or both. This presentation centers around diabetic ketoacidosis and metabolic acidosis due to type 1 diabetes. Type 1 is a dysfunction in the pancreatic cell's ability to produce or process insulin, which causes an excessive amount of glucagon produced by the alpha cells of the islets. This then increases glucose levels through glycogenolysis and gluconeogenesis. This decrease in insulin or complete lack of, combined with excessive amounts of glucagon, results in hyperglycemia in type 1 diabetes. Two types of type 1 include idiopathic and autoimmune. Idiopathic is less common. There's no evidence of beta cell destruction, and it's not inherently genetic. It's most prevalent in Asian and African populations. Autoimmune type 1 diabetes is more common as it is genetically inherited, and there are pre-existing risk factors with this. Over time, the autoimmune type 1 diabetes slowly, progressively destroys beta cells. Environmental factors like drugs, foods, and viruses can increase the risk of type 1 diabetes in people with potential pre-existing risk factors like genetic or family history. This causes autoantigens to form on the surface of the pancreatic beta cells and subsequently circulates within the blood and lymphatic system. Type 1 diabetes, as mentioned in the case study, left untreated can lead to diabetic ketoacidosis or metabolic acidosis. This imbalance in the pH of the blood caused by the excess in ketones circulating in the bloodstream leads to compensatory mechanisms that attempt to reestablish acid-base balance. There's about a 5 to 10% chance of diabetes being type 1, and the incidence is increasing. Peak onset occurs at around 12 years of age. It affects both males and females, and it's most prevalent in white individuals. These patients typically present with a normal weight. The pathophysiology of metabolic acidosis. So at a cellular level, we are observing autoimmune beta cell destruction, which then causes a complete deficiency of insulin. This type of diabetes usually accounts for 5 to 10%, like we previously mentioned, and it's the most prominent childhood chronic disease. The beta pancreatic cells do not function properly, so insulin is either not produced at all, or the little amount of insulin that is secreted by these cells is not compatible with glycemic needs. These patients are typically diagnosed early, and in the two types, idiopathic and autoimmune, it looks at the differentiating between beta cell destruction. In autoimmune, you have the beta cell destruction, and idiopathic, you do not. Rogers writes, cellular immunity, or T cytotoxic cells in macrophages, and humoral immunity, or autoantibodies against islet cells, insulin, glutamic acid decarboxylase, or GAD, and other cytoplasmic proteins are stimulated, which will then result in beta cell destruction and apoptosis, or cellular death. The beta cells of the islet are damaged, and insulin production will decrease, causing hyperglycemia. Glucose accumulates in the blood and appears in the urine as the renal threshold for glucose is exceeded. This produces an osmotic diuresis and symptoms of polyuria and polydipsia. Wide fluctuations in blood glucose levels occur. Insulin deficiency also causes protein and fat breakdown, which results in weight loss. Excessive metabolism of fat and proteins will lead to high levels of circulating ketones, causing DKA. The clinical manifestation. The patient had a seemingly normal assessment on outward appearance. She does appear ill and pale. The only abnormal assessment findings that we find objectively are the Kussmaul breathing, so the deep breaths, and then the acetone fruity smell of the breath. She has decreased skin turgor and her skin is pale. She does have a fever of 99.5, likely due to inflammation. Cardiovascularly, she does have a rhythm of sinus tachycardia. Her GI symptoms subjectively were a stomach ache, and that she has been vomiting and diarrhea and having diarrhea for about 36 hours. Noticeable weight loss has been documented as well. Genitourinary include polyuria, so the patient's increased trips to the restroom. The patient has also been feeling fatigued and reports polyphagia, polydipsia, and the polyuria as well. Lab results were abnormal here, which are indicative of the metabolic acidosis and diabetic ketoacidosis. The potassium elevated due to inadequate insulin. The DKA causes the potassium to shift extracellularly, which can cause the cardiac effects. Bicarb levels are decreased due to the elevated amount of ketones, which consume bicarb and then overall decrease HCO3 levels. The anion gap is elevated due to ketones. These break down into hydrogen and anions in the bloodstream. The BUN and creatinine were also elevated due to the DKA causing increased urination, leading to dehydration and diagnostic of acute kidney injury associated with the potential for renal failure due to the DKA. Blood glucose level was elevated in DKA because it could not enter the cells due to the lack of insulin, so there is excess serum glucose level. Acetone and ketones are elevated due to the broken down fat caused by the inefficient metabolism in the patient with type 1 diabetes. The body broke down bodily tissues, including fat, which then resulted in the elevated ketones and acetone level. White blood cells were elevated as an immune response to the body's stress. Dehydration and metabolic needs were also contributing to this factor. ESR was elevated due to inflammation. The blood pH of 7.23 indicates acidosis. This acidosis from DKA will trigger the brain to hyperventilate, which then tries to compensate for acidosis with Kussmaul breathing. This then causes a low PaCO2, which can be a typical finding in patients with DKA, and the body attempts to compensate, which causes lower PaCO2. This patient is in partially compensated metabolic acidosis, evidence partially due to the patient's PO2 level of 107, which still indicates adequate oxygenation status. As the advanced practice nurse, it's our role to advocate and provide care that is individualized and patient-specific. It's also our responsibility as Christ followers to see the person as a whole and to look at the whole picture as a body of Christ, and to do our due diligence and advocate for patients. The treatment depends on the patient's individualized hemoglobin A1C, which is not listed in the case study, and blood glucose level variations throughout the day. This will help with medication management and future prognosis. The diagnosis is chronic and lifelong, so we will need to prepare and educate appropriately. The patient needs a medication regimen that is effective and works for their day-to-day lifestyle. Potentially using a CGM or a continuous glucose monitoring device could be helpful due to her distaste for her insulin regimen currently and her desire to try something else. There are no available approved PO medications for type 1 diabetes, so insulin is what this patient will have to take in order to maintain compliance and health. Referring to a nutritionist and a diabetic educator could be helpful for this patient and could help her understand the best foods to eat and the appropriate times to consume them in conjunction with her insulin regimen. As far as mental health, a counselor could be beneficial to this patient as well. New diagnoses and lifelong chronic diagnoses can contribute to anxiety and depression rates. So equipping with the patient with all the coping mechanisms and resources that we can will benefit her in the long run. The whole family should be involved in education and patient management and care due to her age. The fact that she has her brother who is diagnosed as well could help her with understanding medication management, lifestyle changes, and mental well-being as well. The case questions I have: what are 3 abnormal lab results in this case study that are diagnostic of DKA? Sodium, potassium, and fasting glucose levels. The kidneys were unable to regulate sodium levels effectively with the AKI caused by the DKA, likely due to dehydration from the polyuria. The potassium level is high due to the lack of insulin available to force potassium out of the bloodstream into the cells. This can be contributed to dehydration as well and the cellular breakdown due to the DKA. The blood glucose level of 554 could indicate an excessive amount of, it does indicate an excessive amount of blood glucose, which is diagnostic of DKA. The beta cells of the pancreas are not allowing insulin production or secretion to happen, so the blood glucose levels remain high. Is a blood pH of 7.23 abnormal for someone with DKA? It's abnormal for a healthy individual, but it is an expected finding in this particular instance. DKA blood glucose levels will remain extremely high and hard to decrease with an everyday insulin regimen, so closer evaluation and hospitalization is required until the patient is stable. The patient's elevated potassium, so there's what is the reasoning behind the patient's elevated potassium level? It's likely due to the lack of insulin and the inability of the body to allow potassium intracellularly. This will result in excessive potassium in the bloodstream. The EKG should be conducted, which showed sinus tachycardia, and then continuous heart rhythm monitoring should be implemented until these levels normalize and the DKA resolves. These are my references. Thank you so much for listening.